Hi, my name is Ravi Vij. I'm from My Cancer Haven, and today in the Conversation with Cancer Experts series, I have the fortune of having Dr. Samir Parekh with me. He is director of the Center of Excellence for Multiple Myeloma at one of the most established myeloma programs in the country at Icahn School of Medicine, Mount Sinai. And he's one of those rare, physician scientists who can bring a perspective not only into the clinical realm, but also into biology. So we're going to talk today about targeting protein degradation pathways in myeloma. Welcome, Samir.
Thank you, Ravi, and thank you for the kind invitation to speak on this exciting topic. We use targeted protein degradation by various IMiD molecules, uh, and this has been the mainstay for myeloma treatment for many, many decades. But before we get into that, I think it would be amiss if we didn't talk about actually how the drugs came about
Oh,
and
yeah,
how
that
they
is.
were used initially. They were actually meant for pregnant women with nausea, and indeed caused, unfortunately, a lot of babies with fetal abnormalities in Europe, and the drug was actually withdrawn in 1961, as you show here. Um, Thalidomide was continued as a treatment for leprosy, and people continued researching it in the lab for its anti-angiogenic effect. And around the 90s, due to a patient who was treated in Arkansas with relapsed myeloma, and in fact, it also gives the importance of family in the treatment of patients with myeloma because it was the patient's wife who persisted and found a recommendation from a eminent scientist at Yale to give this drug, and then the Arkansas team gave the drug, and the rest was history because the patient did indeed go into remission, and then thalidomide was approved for the treatment of myeloma, and it has now given way to a whole series of second, third, fourth generation compounds, each one being more effective than the other. And as you can see here, they are not just being used in multiple myeloma, but as we learn more about them and um, how they work, what the substrates they are using and things like that, they are actually being used more widely in different hematological cancers, including MDS or myelodysplastic syndrome, and also non-Hodgkin's lymphomas. So this is really an exciting drug class. They are all oral compounds, so patients all over the world find them very easy to use. And I really think it's an important concept to know as um, patients and caregivers about the science behind these drugs.
So obviously, it's remarkable the story that you told us about the patient in Arkansas. And as you said, it was thought that it was their anti-angiogenic activity, that is, the tumor's blood supply would be shut off. That was the basis for their initial study. But now they're called immunomodulatory drugs. So what happened that why not angiogenic drugs?
Right. So the precise mechanism of action was not known for these drugs for many years, and we continue to unravel different and new important aspects about how they work. In fact, my lab collaborated with the University of Oxford in an international study with one of the more recent compounds called iberdomide. And we found for the first time in the bone marrow microenvironment that these drugs activate the immune system T cells and natural killer cells. And this was shown for the first time for these drugs that not only do they work on the tumor cells or um, have direct anti-tumor activity, but actually through the immune system indirectly also kill tumor cells. And we are actually using this aspect to design a way where they can help the next generation of immunotherapies, which are coming in myeloma, CAR Ts and bispecifics, which both our institutions and I'm sure a lot of the audience members would know of as well.
Yeah, so I think that obviously it is often the case, or has been at least often the case in new drug development in cancer, that we find drugs are active and then we try to figure out why they were active. And as you're saying, that it has got a lot of different potential actions, but I think that the molecular basis of its activity has also recently been better understood. So, could you walk us through how this whole generation of drugs works?
Sure. So this is a nice cartoon illustrating what these compounds do in a simple manner. And in green or teal over here is the E3 ubiquitin ligase protein. And this is a protein that works as a chaperone. It takes proteins that are marked by ubiquitination for degradation. So our body has a very unique system for getting rid of the waste that we produce. And to get rid of it, the proteins, once they have done their function, they are marked with a tag called ubiquitin. This tag is recognized by the protein shown here in green, and then this enables that protein to then ultimately go to the waste bin of the cell, which is called the proteasome. So the way the thalidomide and related groups of compounds work are they work as glues for bringing the proteins meant for degradation into the pocket of this ligase complex. So then the ligase complex, like a garbage disposal truck, takes them to the proteasome where the actual degradation takes place. What has been evolving is the understanding of how this happens. What are the proteins that are key to be degraded through this mechanism? How are they recognized? And in fact, what we learned more recently are that transcription factors, which are molecular switches that can turn on or repress genes, uh, Icaros and ILOS are two examples of transcription factors very important in myeloma. These are actually directly degraded through this mechanism. And in fact, this is how the IMiDs actually help in myeloma because the degradation of these proteins helps reduce or switches off oncogenic genes like MYC and IRF4.
So I guess looking through the compounds that we have come through, can you walk us through? You mentioned thalidomide. Obviously, I don't think it is used very much in the United States anymore. We have better drugs, I guess. So why? Can you talk us through how the development has proceeded?
Sure. So thalidomide was the first compound, as we discussed, and since then, the second generation compound, which was lenalidomide, also known as Revlimid, has been tested, and this is one of the trials from the UK, which looked at combinations of drugs using either thalidomide or Revlimid, and in the curves, you readily see a separation with superior uh, progression-free survival in patients that receive Revlimid. And indeed, not just improved efficacy, but the newer IMiD derivatives also have a different safety profile. So if we go to the next slide, you will also see that thalidomide, which is marked in the orange bars, has more neuropathy and more risk of pulmonary embolism as compared to the Revlimid. And Revlimid is a safer drug in that way. It may cause a little bit more neutropenia, but actually, due to the decreased neuropathy, has completely replaced thalidomide in our practice. And in fact, we have patients taking it for years and years and years.
So, and then came pomalidomide.
And then came the next generation. So the third generation of drugs was even more potent than lenalidomide, and pomalidomide was tested in patients that had either been exposed to lenalidomide or were refractory to lenalidomide and showed efficacy, and this provided the basis for its approval. And in fact, we are finding it to be much more potent. It is being used in combination with the monoclonal antibodies and still around as salvage therapy with patients that have relapsed myeloma.
So let's talk about where we're headed. Seems like the story hasn't stopped, and that we have a whole new generation about to hit clinical practice. So, first of all, what is the reason why we need new drugs?
Right. So, um, although Revlimid and pomalidomide are effective, as we follow patients that get these, we have learned that the effect of the drugs does not sustain remission in all patients. And this is an example from the UK MRC study showing that patients that got Revlimid maintenance did in fact break through, and this was particularly true for the patients that had both MRD positive responses and even deep MRD negative responses. Uh, we therefore need drugs that will be effective or more effective than even Revlimid to complement the current treatments for myeloma.
So I gather that a new generation of agents called cell mods or protein degraders are what we are going to talk about next. So, what is a cell mod?
Yes, so what uh, happened was a greater understanding about the mechanism of how these drugs worked came about in the last few years. And in fact, what really changed was that the E3 cereblon complex that we were studying as scientists actually remarkably n- needed to change in conformation or folding to accommodate certain substrates. So this was shown using crystal structure experiments recently, and we then learned that actually the way iberdomide or mezigdomide and these compounds worked was by changing the conformation of the complex, which to allow new substrates to get degraded. And this was critical understanding because through degradation of these new substrates, we could achieve myeloma control or MDS control. And in fact, the new drugs are far more potent and in fact, in the case of iberdomide, even have less side effects. So we are seeing drugs that are more potent and perhaps safer. So these indeed are going to be the next generation in this class of compounds.
So, you mentioned these being more effective. So, I guess these are more effective because they are more able to effectively, at the molecular level, exert better profiles?
Yes, so the reason they exert better profiles is that the previous class of compounds existed in two forms. They had the mixture of isomers called R and S isomers, and the R isomers tended to bind less efficiently, and this led to decreased conformational change and decreased degradation. With this knowledge, we are now able to isolate and develop compounds that exist as a single isomer. And as you can see, one of the measures of efficacy is binding to cereblon. And the binding affinity, as is shown in this table, is far greater in terms of log units for iberdomide and mezigdomide as compared to the previous generations like lenalidomide and pomalidomide. And this binding then leads to the downstream effects that we discussed before, which are conformational change and substrate degradation.
So it seems like these drugs, iberdomide is active even after cells become resistant to the earlier generation of IMiDs.
Yes, with a greater understanding of the mechanisms of action, we are also learning a little bit more about the mechanisms of resistance. And a couple of the known mechanisms of resistance to IMiDs are a decrease in the expression of the target, that is cereblon, and mutations in the actual cereblon protein and the binding pocket. So we have now evidence that the new drugs can work even when the levels of cereblon are reduced or where there are mutations in the cereblon binding domains. And this is what is shown in this slide. Um, the activity was tested in a phase 1 study, which was the MM01 study and is now published. Um,
So I guess this set of images also shows more of the same.
Yes, this is more lab-based data where they essentially reproduce what goes on in a patient in a lab model where there is a mutated clone of myeloma cells. And we see here that the degradation with the newer cereblon modulators, iberdomide or mezigdomide, is still retained uh, despite having the mutation. And the activity in contrast to lenalidomide of mezigdomide is far greater in the setting of these mutations.
And so, obviously, drugs in myeloma start their journey alone, but they move into combination therapy. So, I understand that these drugs have the potential to be combined with other existing compounds that we use.
Yes, they are very good partners with the current and actually even incoming myeloma drugs. And so carfilzomib, bortezomib, daratumumab, even CAR-T and bispecifics are actually good drugs that will benefit from these um, compounds, and these are all being uh, combined in various preclinical and clinical studies. So they will definitely come on board in combination studies and potentially um, be good replacements for Revlimid or pomalidomide down the line.
So, what about cemsidomide? I guess this is another drug that has activity in IMiD resistant patients.
Yes, so cemsidomide or CFT 7455 is the latest in this class of compounds, and actually is an exciting class of molecules called molecular glues. And um, these molecular glues actually are able to degrade substrates or neosubstrates. Here they are showing the degradation of iolose very, very potently. If you see on the right side, a number of myeloma cell lines have been treated with this compound, and the relative potency is 1,000-fold compared to the pomalidomide image. And this really is exciting because we think that we can use tiny amounts of these compounds to achieve anti-myeloma efficacy, perhaps making them even safer. So we will have uh, good anti-myeloma control, but greater safety with a coming class of drugs.
And you hinted at this group of compounds not only affecting directly the myeloma cell, but also the microenvironment.
Yes, so we have looked at this in patients with both imerdomide and mezigdomide and found that they actually activate T cells and NK cells. And in fact, in an upcoming manuscript, we're going to show that they do this and can actually dissociate the normal physiology. As T cells get activated, they usually get exhausted. But here they are able to keep activating them without the classical exhaustion marks happening. So they continue to have anti-myeloma efficacy. And this is especially important in the context of patients that have gotten BCMA targeted therapy. So, as more and more patients are getting bispecifics or ADCs or CAR Ts, this will be important because the activity of these compounds does not seem to be deterred in setting of BCMA exposure.
So it seems like these have activity, as you hinted, even in patients who have been exposed to BCMA products. So that tells you that options for BCMA refractory patients are growing. But also, I thought I heard you hint earlier that these drugs have the ability to actually augment the use of bispecifics in CAR Ts that are already showing great activity and not only be restricted to combinations with more traditional drugs.
Correct. So there are already clinical trials with the traditional IMiDs and bispecifics that have been done and show excellent results with very high response rates and even durable responses. I think this is going to translate to similar exciting results. We have already preclinical data that suggests that these synergize with bispecifics and CAR T. I think there's potential for even using them with anecdotal cases to salvage patients that are post CAR T and post bispecific. So definitely a lot of room for um, their use in a post CAR T or post bispecific world.
So, what are your key takeaways for our audience with these new generation of drugs on the way?
So I think the overall message is that this is a very important and exciting class of drugs. Uh, the protein degradation strategy that we've been using for years, as we have learned more, better drugs are being invented and better drugs will be approved and they will potentially not just be more effective but also safer and they can work not just directly on the cancer cells but also on the immune system so we can harness this by combining them wisely with other anti-myeloma drugs that are currently in our armamentarium and now bispecifics and CAR Ts that have entered the armamentarium. So this is really where field is going, and I'm glad I was able to participate in the conversation with you on this.
Oh, I really appreciate you taking the time to educate the audience about these exciting developments. And I hope that I can count on you to come back and talk to us about further developments in the future.
Sure thing, Ravi. This has been great.
Thank you very
Thank you.
much.